Hey everybody, we want to welcome you to Sister Circle. We are live. First of all, I must tell you that prior to us going live, we was in with Dr. Kellee, asking all types of questions. We are ready. Tonight is the night. And so we're so excited to have Dr. Kellee on here. You guys, just so much knowledge she was spitting before we went live. And so we're excited about what she's going to bring tonight. Remember, we take questions live. So type them in on our website and we will go from there. So Dr. Kellee, before we even start with questions, just tell us a little bit about yourself and your business and your practice.
Sure. Hi. So glad to be here with you guys. Thank you so much for the invitation. Not often that I have another namesake that spells their name just like me. So of course it got my attention. But I am Dr. Kellee. I'm a board certified internal medicine physician, speaker, patient care advocate, and soon to be author. And through my programming, I help patients become better educated consumers so that they can improve their healthcare outcomes. I'm very passionate about ending healthcare disparities in Black and Brown communities. I am on all social media as Dr. Kellee, DocTorKellee. I also have a new healthcare journal that just launched in pre-sale on Black Friday. And so I will definitely be sharing that information, but that website is www.mymedicaljourney.shop. And I'll make sure to put that in the chat. But I'm so glad to be here with you guys. I'm a hospitalist, so I work in hospital setting. So I take care of pretty much anything you have to come to the hospital for: heart attacks, strokes, COVID, of course, and pretty much anything else that's non-surgical falls under my umbrella. Yep, you got it. Perfect.
All right, awesome. So we're going to jump right in, and I'm glad you brought up COVID. So, so my first question, as we see everything on the news pertaining to the vaccine, so and especially people of color, we are concerned, and so we don't know what to do, and we're reading articles. So, from your professional opinion, what are your thoughts on the COVID vaccine?
So we kind of talked a little bit about this before we went live, but from my standpoint, and I do have a background in clinical research, phase 1 clinical research. And so it is really unprecedented to have a vaccine go from conception to the market in an 8-month period. I mean, it's essentially, it just doesn't happen that quickly. I don't doubt that the vaccine is going to be effective, or that it is effective. And I think from what we are hearing, that both of the companies, Pfizer and Moderna, who are the two companies who are basically pushing for launch from the FDA, that both of their vaccines are efficacious. So that's not really where my concern lies. My concern lies with the fact that we don't have any safety data. And for your viewers who are not well versed in clinical research, anytime a medication is brought before the FDA, you have to present safety data. And so, yes, you have to prove that it works and it does what you say, what you're marketing it to do. And in this case, it would be to prevent the coronavirus. But on top of that, they're also looking for safety, right? So you can't be, it works, but you might lose your arm, right? Or it works, but you might lose your vision. Okay, so usually that's not a good drug, right? We're happy it works, but we don't want these side effects, right? And so if you look at any pill bottle, whether it's over the counter or anything you get prescription, all of those side effects that they list came as a result of safety data. And so patients take those drugs in a controlled environment, a controlled setting, and it is documented. Oh, they had a headache. Oh, they got nauseous. Oh, their arms started itching, whatever happened. And all of that data is reviewed by an independent review board. And all of that has to go before the FDA. So to circle back to the original question, we don't have, or it has not been publicly released at this point, the safety data. And usually you have follow-up visits when you're initiating a medication. So yeah, you may be fine and not have any side effects for the first 3 months, but what happened after that? And what happens if you give it to somebody with high blood pressure? Does it interact with certain medications? What happens when can you give it to cancer patients? Is the same vaccine effective for kids as it is for adults? Do you need one dose or do you need boosters? Is it lifelong immunity? So there's so many questions that have to be answered. So from my standpoint, I don't doubt that the vaccines work. The issue is the safety data and the fact that it's so new. And I'm hesitant for our people always, because we always end up being the ones that get guinea pigged. Tuskegee to name a really important one. And I know that there's been attempts to get some of our historically Black colleges and universities on board to be the first to take the vaccine. And so all of that gives me a little bit of pause. So I will say it's early for me. And I know that the push is that, healthcare workers are going to have to be first in line, but there's not enough vaccine, nor can they produce enough vaccine for even healthcare workers. So I just think we need more time and need to see what the comprehensive plan is going to be for rolling this out.
That's awesome. So I think, and you guys jump in wherever, whatever questions you guys have. But I think for me, the next question, when it comes to COVID, so in light of the vaccine, what do you just encourage people to do? If we're still waiting to get some good clearance on the vaccine.
Yeah. So to be honest with you guys, I'm assuming that the vast majority of your audience is in the state of Texas. If you look back to the Texas State Department of Health, the recommendation has never changed. Now, our governor said one thing, but our health officials from the state level have been advocating for stay home since March. That never changed, even when they started to open up restaurants and bars and so forth and so on. If you look at the Dallas County website, which I was on daily for 7 months, we were code red every single day, every day. We have never dropped to the point where stay at home was no longer the recommendation, if that was an option. So I would say, with the fact that we are surging, not just here in Texas, but nationwide, that for folks who can work from home, to work from home and to really be mindful of exposing themselves. And I know it's a difficult time of the year. People feel like they gave up their summer and now you're asking them to give up their holidays. But we really have to make some changes. And the reason I know that to be true is because our hospitals are full of nothing but COVID, very few other things besides the coronavirus at this point. Patients in our ICU, everywhere. I mean, it is literally all we're seeing at this point. And a lot of that is because people refuse to wear masks. They refuse to be socially distant. I understand, especially for our small business owners. I am one, so I can respect the hustle. But at the same time, you have to come up with other ways to support small businesses, your favorite restaurant, without putting your family at risk. And there are ways to do that. You can order from any of the food delivery services. You can actually order your food to go and still support that business and get whatever it is you're wanting without being in a restaurant. People are in restaurants. The tables are just like they were this time last year. There's no social distancing. You can't eat and wear a mask. So that alone is a super spreader event. And the fact that our nursing homes, our hospitals are full of coronavirus patients, it shows that we are doing the wrong things. We're doing the wrong things.
That's good. So go ahead, Erica.
I do have a question. So since we're talking about the coronavirus and how it has an adverse effect on our community as Black people, in your opinion, just your opinion, how do you feel that our Dallas mayor has written to the CDC asking to prioritize Black and Hispanic people to receive the vaccine prior to anyone else?
So I understand where that question or where that desire is coming from, because specifically for Dallas County, Hispanics and those who live in dwellings where they live with other people. So our Hispanic community is being hit so hard because one, there are frontline workers a lot of times, and two, they live multi-generationally. And there's a subset of African Americans that also live multi-generationally. They'll have the grandma, the aunts, the uncles, everybody lives in the same house. Now, grandma's not leaving, but everybody else is. And so they come home and the whole house gets COVID. That is not uncommon. When I was at Parkland, it wasn't uncommon for us to have a whole family hospitalized. That was not like a rare thing. And it's because they are the people who are domestic workers. They're working in your grocery store. They're working, in situations where they're constantly inundated with people. And so it is not surprising that they're being hit the hardest. The same with African Americans who tend to, again, not go to single family homes. So I understand where that is coming from the standpoint of trying to prevent the number of deaths related to the coronavirus. But at the same time, like, I stated earlier, again, I do not at all doubt that the vaccine is actually going to be effective. I just have concerns about the fact that we don't have all the safety data. And that we don't know long-term effects. And most of the time in those households, Black and brown, those folks are not all healthy normal. So you're talking about folks with diabetes, folks with high blood pressure, folks who are overweight, already have issues. And so to give them a virus that we don't have long-term safety data on, I think is a little bit premature, although I understand where his level of concern is coming from and what he's trying to do, but he's also not a healthcare professional. And I would probably say he does not have research experience. So he may not even understand what he's asking for. But again, that's my take on where things are. So again, not to say that it's not working or it won't work or anything like that, but this doesn't need to be another Tuskegee experiment.
So just last question. What's the general time frame when we put out a vaccine?
Of my head.
When we're pushing out a vaccine, because I do feel like this is pretty quick that we were able to pull this together. I know you said it's a lot of research. Do you feel like they're rushing? They're rushing it, or
what's the typical length?
I feel like, what's the typical length that it takes to, develop a vaccine for something?
So I would say, I don't know that there's a specific time for a vaccine, like, okay, it's going to be X amount of years. It really depends on if things have to be tweaked. If, okay, our data from this first arm of the study is inconclusive, there's so many variables that go into it. Okay. And things like, well, we want to do this study again, or the FDA or the investigational review board may say, no, you need to do this, that, or the other thing. So, you literally could be trialing a drug for years before it actually makes it to the shelves. Yeah. And, that's why, because of the amount of time that drugs and pharmaceutical companies spend trying to get a drug through, that's why they get that 7-year period of exclusivity, because they've already spent so much money doing the research, doing the data, doing the safety, following up with patients if that's necessary. So they get that 7-year window where nobody can make it generic because they have to try to recoup some of what they put in. So, that's a hard question to answer, because a lot of what triggers them to have to stay in that research phase longer is data driven. And so it just depends on, okay, how is it efficacious across the board? What if you give a drug and you realize, oh my God, it doesn't work very well in patients with sickle cell for whatever reason, or oh my God, we're noticing that our patients who've had strokes have this effect. So that's what drives how soon something comes to market. So if you realize, oh my goodness, all of our stroke patients are starting to have issues, then now you got to do a controlled study for that specific variable. So it could take years.
Yeah, I'm also even thinking about, if other people, if they're taking other drugs, like what the,
right.
what's the
interaction?
Interaction between the other drugs.
Right.
So
But that's part of it. That's why they start in healthy, normal people who don't have anything else that they're taking. They're not taking supplements. They can't do any of these types of things, so that you can kind of get a clean slate to see if we got a lot of issues with this and people with nothing, no other medications.
right.
Then you know you're gonna have issues with people who are taking 6, 7, 8, 9, 10 things. So that's why I'm saying 8 months is, and part of that time they were in development, right? So you're not talking about 8 months of research. You're talking about some of that was development and mass production to be able to do a research study. So you're not talking about a clean 8 months where, oh my God, we've got 8 months of safety
already
data.
been working on something.
Say it again.
I'm just throwing out conspiracy. I said, unless you have already been working on something, not trying to, conspiracy theorists, like that. But I'm just saying, because how long did it take for a flu vaccine to happen? And now we're all, some of us take it, some of us don't. How often does that vaccine change or get updated? All those types of things.
Well, I think the first thing that it's hard for, especially for our generation, because none of us have been through a pandemic before. Right. And so what is really hard for this generation and those currently around, especially those younger, that's who we're really having a hard time with, is the fact that we live in an instantaneous society and we expect to place our order at window A, turn that corner, pull up to window B, and someone has packaged your solution and they hand it to you. Wow. That is not how this works. That is not at all how science works. And so the fact that people are having to live this out, like we are writing this story right now, right? So we missed measles, mumps, and rubella, right? By the time we got here, there was already there, right? So we missed all of that. But the people who had to go through the paces and died of measles, right, and died of rubella, those folks had to live through it. And now we have the experience of what they went through, and we got a vaccine, right? But that wasn't oh my gosh, we have this rash, but here it is now. In 8 months, here's your cure. It doesn't work like that. The flu gets tweaked every single year. So it's not like they make the flu vaccine and then it just sits in a freezer waiting for September, October to come around. They look at a lot. Yeah, it takes a lot to make those vaccines every year. They're actually looking at what viruses are surfacing. And coronavirus is not, SARS is not a new virus. This is a new strain. Right, yeah. So if you look at your Lysol and all that business, coronavirus was already there.
It was on there, yep.
Right. So we're not saying that, oh my God, this is a brand new species of virus. No, this is a new strain that is very potent, very virulent, and very, very, very infectious and contagious, more than the flu. So, that's the part that we're having a hard time getting people to understand, is that we came in at the right time. There's vaccines for the vast majority of things, but if you circle back to 1900, a lot of people died because this wasn't in effect. So we're writing the story, and it's impossible to write this whole story and live it out in 8 months.
Yeah. So I think, and I don't know if you guys have another question COVID related, I was going to switch to just general health concerns. So when we think about women of color, especially African American women, what are common health concerns that you see? And what would you just encourage us to be thinking differently about?
Yeah, so we see a lot of high blood pressure, a lot of diabetes, a lot of high cholesterol, a lot of heart disease, and a lot of late stage cancer. And so again, one of my platforms is on patient advocacy, and that's on both sides, teaching patients to be better advocates for themselves and make better decisions. But, a lot of our history and the reason why we are predisposed to a lot of things is because of our history and how things unfolded for us in this country. We were denied access to healthcare, denied access to jobs, put into ghettos, you know, insufficient housing, insufficient education. So all of those things are what we call social determinants of health, right? So if you are underemployed, so you don't have a high school diploma, okay? So you're working at wherever and you're doing a $10 an hour retail job, right? Not knocking anybody who does that, but this is how we get to where we are. So then you have to figure out, okay, how do I afford rent? Paying for a car, paying for children, paying for healthcare if your job even provides it, because a lot of companies will basically cap your hours so that they don't have to, you know, provide healthcare. So let's say, you know, the mandate is that you have to have 40 hours a week. They'll give you 38.
Mm-hmm.
And so they don't have to provide health insurance for you. So on the free marketplace, as an individual, it costs hundreds of dollars for an individual to get insurance if they're healthy. Mm. What if you're covering a household? So you're asking people to make decisions, and not just the those that are underemployed, but also our elderly. They're all living on fixed incomes, right? So you're asking them to take $800 a month and pay everything with it. And that's just not how this works. So as a result, people have to make decisions. Do we feed the family, or do I go buy this $50, you know, these $50 worth of prescriptions? Right. Most people feed their families. Most people pay the light bill. You live in Texas, most people make sure that the lights stay on and the air stays working because you can't live here without it. So we're asking people to make life or death decisions because you don't notice the effects of your blood pressure being high right away, but you do feel that there's no air, right? You don't recognize that your blood pressure, right? You don't know that your blood pressure, your blood sugar are out of control until your vision gets blurry, but that's months or years down the line. Yeah. So this is why our people come in with advanced stages of disease, because we have to make decisions that our counterparts don't have to make. Yeah. And so without the education, you don't know that you're harming yourself. So you show up to the emergency room now because you can't see or because you can't feel your leg, and you walk out and you got 10 medications, you got kidney failure, you now have to start dialysis, all these other things because you made decisions. And you didn't necessarily make them out of like wanton disregard for your health. You made decisions based on what your household needed. And so that's the case for the vast majority of people. And so we see tons of high blood pressure. People live under stress. They're trying to figure out how they're going to pay the bills. COVID hit and a lot of people got laid off, can't get their hours, but bills are still due. Right. So that is very common. And we always present later than our white counterparts. There is data to back that up in just about every disease process. Black women, as far as breast cancer is concerned, we are not at highest risk for breast cancer, but we die at a higher rate.
Wow.
Yeah. Real talk.
Yeah. So one of the things you mentioned was high cholesterol. So and so I'm going to start by just saying, forgive my ignorance, because when I go to the doctor, you know, they're testing for it, but I'm like, now I don't know what it's saying and what. But I guess my question is, what's the impact of high cholesterol? Like, what
is it?
Yeah, what is it and how is it showing itself?
So high cholesterol is basically what they're measuring is the amount of the particles basically that are in the blood. And so there's some people who, when you draw their blood, it's literally like Crisco. I mean, like there's so little blood content and it's like a congeal. It's literally almost like having grease in a tube.
What? My mind can't process that. What?
Yeah. So I give an analogy to patients. When I talk about the arteries of the body, think of it like pipes.
Yeah.
Right. And so if you put grease down your pipes, what's going to happen?
It's going
to get clogged up. It's the same principle. The body is essentially a bunch of tubes that are fed through pipes. And so you start clogging the pipes, then blood flow can't get through. And the blood flow is where we get oxygen. That's how nutrients move around. That's how every cell in our body gets what it needs. So when you start blocking up your pipes, for a while, everything's going to keep working, right? Keep working, keep working. And one day, you're like, what's happening here, right? Same thing with the body. The body has an innate ability to compensate. It will keep working with you. The heart's just going to keep trying. It's going to keep pumping against a higher pressure. So it's got to get bigger to do that. And it just keeps trying to compensate until eventually it's like, I can't stretch myself anymore. Oh. And that's when you start getting symptoms. That's where things start to manifest. And people feel like, well, man, I was fine yesterday. You weren't fine yesterday. Yeah. You just didn't know you weren't fine. And your body is to the point where it's telling you, okay, sis, you got to do something different. This isn't working. So there's several components when we say your cholesterol. Now, there's a subset of people, specifically Indians, even those with Indian descent. So like they're still Black and brown. Our Trinidadian family, anybody who's got true Indian descent, those folks inherently genetically have high cholesterol, really high. Wow. And so they are at high risk for stroke and all that kind of thing. African Americans are too, but not to the same extent that they are. I mean, I've seen some of their cholesterol levels and it's in the thousands. Now, for us, it's a lot of diet dependent. And motivated by our diet. Some of it is genetic, but a lot of it is diet. And so if you got $10 and you got to feed 5-6 people, you're probably not going to Whole Foods, right? You're probably
going to get something, a bunch of bananas in there.
That's if that. So you're basically going to be getting a bunch of things that are canned or processed or boxed. Or fried, because calories are cheap, right? Mm. And so nutrients cost, and so that's why our people are at higher risk, because you just loop this right on back into the conversation we had a few minutes ago. When you got decisions to make, you do what you can with what you have left, right? Mm-hmm. And so that's how we get there. So when you're looking at your cholesterol, there's your triglyceride level, which should be at 150 or lower. And then we have good cholesterol, which is the HDL cholesterol. And we have bad cholesterol, which is the LDL cholesterol. Now, I won't get into the specifics about what that actually correlates to, but it's basically the size of the particles and what they do in terms of for the body. But essentially, your LDL cholesterol, you want to be low. And your HDL cholesterol, you want it to be high.
Okay.
Because that's the good one. So there's really 3 components that we look at: triglycerides, the LDL cholesterol, and the HDL.
So cholesterol is connected to stroke. Like, so when people have stroke, okay.
Sort of.
Because so, like everybody that I feel like has a stroke, and that was one of my questions. I always feel like it just came on. Like they always kind of make you feel like, there was nothing before, so it just hit, and they had a stroke. So I that was my question. Like, how do you
remember? So think about. And people have a hard time conceptualizing things in the body. Think about it in terms of just about anything else, right? How many times have you been driving your car and all of a sudden a light comes on? Now, did the light did just come on, but did the problem just start?
No.
Right? So when people say, yeah, they had a stroke, I was fine, and then I wasn't, that part is true because they didn't feel any symptoms.
Yeah.
Right. They didn't feel that their hand was numb, or they didn't have slurred speech or any of that kind of stuff. Those symptoms do start abruptly. It just happens. Sometimes it happens while people are asleep and they don't even know, and they wake up and it's like, I can't even move my left side or whatever. But the underlying issue did not just start.
Gotcha.
That's good.
Right? So they've had high blood pressure. The body just is done compensating. It's like you've pushed me as far as I can go. I can't take anymore. And now I'm shutting down, or, whatever the case may be. So yeah, nothing just like, you don't have stone cold normal blood pressure today and then tomorrow it's just out the roof.
Right. So Dr. Kellee, quick question.
Yeah.
So I go to the doctor, I get all my, it's my annual, checkup with my primary care. Numbers are fine, or everything is healthy in the average normal range. But I have complaints about something going on in my body. Mm-hmm. How do I get, or how do I get my doctor to really, take me serious about the things that I'm feeling and all these things, besides just looking at, oh, your tests are normal, this and that and the other. There's nothing wrong, but I know my body and I know what I'm feeling. So what do you say, or what do you do? I know go get a second opinion and things like that, but what can I really do, or who can I turn to really advocate for myself about what I can get done?
Absolutely. So let me tell you the example that I use when I'm talking to people. So Serena Williams, very recognizable by name, recognizable. She could walk in and nobody's going to be confused as to who she is. We agree on that, right?
Correct.
Mm-hmm. If she has to advocate for herself, you absolutely know you have to advocate for yourself, right? She is a millionaire and she has access beyond access. If she has to stand up for herself in the hospital and say, I need a CT of my chest because I'm telling you, I have a blood clot. There is something wrong with me, right? If she has to say that, and then they do the scan, and of course she had a blood clot, average everyday people have to do that, right? You have to be advocating for yourself because we are inherently not heard. And so part of that issue is, one, knowing what you should be having, when you should be having it, and having a provider, whether that's a doctor, a nurse practitioner, a physician's assistant, whoever you're seeing, that can hear you and see you.
Yeah.
Because a lot of times, and I'll tell you as a physician, the demands on us are immense, especially now in the middle of a pandemic, and everybody is stressed and stretched. And that's not to make an excuse for colleagues who are not doing everything that they should be doing for their patients. But I will say this, you have to be present. And that's really part of the reason why I designed my journal, was because patients have to come in educated and on your P's and Q's. If you show up and you just sit there and you let them tell you, yep, labs are fine, everything's fine, see you next year, and you just walk out, well, then you seem satisfied. They saw you, and that's that, right?
I'm trusting you. You're the professional.
Exactly.
So, okay, am I feeling that? No, that maybe it ain't really hurting that bad. I don't know.
Like, I think that no news is good news, Dr. Kellee, right? So if I go in, I'm feeling some type of way, but you said I'm good. So
my numbers look good.
And I don't want, especially people of color. Like, I remember when I grew up, my mom never went to the doctor because she don't want to hear the bad news.
Right.
So, and I'd be like, well, maybe we should go. Like, my first time, real talk, at the dentist was when I was grown, like 25 years old. Because my mom was like, yes, because my mom was like, oh, the dentist hurt, so we not going to the dentist. So I didn't go to the dentist at 25. The dentist looking like, this is my first time getting it clean.
No way.
Yes, because I think Black people, we just don't. I mean, and Dr. Kellee is saying it. That's not the stuff we do. And if we're afraid, we definitely not going to the doctor. Like, if we think you want to tell us we got cancer, then I'm just going to stay at the house and I got cancer.
Exactly. But that is exactly what happened.
I'm a Google doctor. That's
exactly. Wow. That's exactly. But people will get to a breaking point, and if they don't break, then it's their daughter or son or whomever, and they're like, "I'm taking you to the ER."
Yeah.
Well, okay. If you had come in a year ago, 2 years ago, when you first started having this issue, we probably could have treated it and saved your life. But now that it's stage 4 cancer and everywhere, now we're planning your funeral. That is what has to stop. That is what we that's what we see. And it's unfortunate. It really is unfortunate. But when you feel like, okay, something's not right here. And I was saying the thing about basically making sure you have a rapport with your doctor is so that when you speak, they listen. Because we do see a lot of people who is like, oh, this hurts. Oh, that hurts. This, and it's kind of like if you have kids, right? And they're like, oh, my stomach hurts. You're not like, oh, let me rush you to the ER. You're like, go on in there, see if you can go to the bathroom. Let me give you some. Right. But think about that when you're seeing 20, 30 patients a day and everybody's like, ooh, but my arm, ooh, but my toe. It's like the squeaky wheel is what gets the oil. So if you come into the doctor's office like, I got to document it. On Friday, it happened, and this is what I was doing when it happened. And then last week, when I was doing, then you got a leg to stand on, right? Because a lot of times patients will come in and they're like, well, I don't really know. And you're like, well, describe it to me. Well, I can't really describe it. Well,
2 weeks ago, I don't
really remember. But see, that's a different, like, what do you want? What are you expecting them to say or do about something that you can't even pinpoint? Right? And they got to see 30 more people just like you in a 15-minute window. So you got to come in there on purpose, with purpose, which is why I designed the journal for our people, because it gives you a place to put down, okay, these are my questions. And this is the answer, and this is who gave it to me, because we come in, our meds are in our purse at the bottom with some gum on it. It's a white pill. You know how our people do.
Right.
And so you're like, what is happening here? Especially in the hospital where we're not your doctor. We're seeing you in an emergency. I need to know what you're taking. Do not describe your pills to me.
Right.
What are you taking? What are you taking? So there is a difference. Yeah. And why?
You don't even know why you're taking it.
I hear people all the time, I'm taking Crestor and it's for my high blood pressure. No, ma'am, it is not. It is not. It is not. But we're so accustomed to being overlooked and so accustomed to giving that problem to someone else to handle. And that's why we get subpar care. You can't say, well, you're my doctor, you figure it out. My heart's fine. My heart's just fine. You are the one who's going to suffer the consequences.
Right.
You go into that doctor's office, ma'am, I had chest pain on Friday and I was sitting at my desk and I had just eaten this. Okay. And then it happened again. You have to come with that level of detail and you have to come in just like, no, ma'am, you're going to tell me something. The same way we come to the schools, right? And show all the way out when somebody does your child wrong.
That's right.
That same energy, we're talking about your health care. And we don't. We always want to punt that to somebody else. You cannot do that because a lot of practitioners are on the wheel. Next. And if they don't see anything glaringly obvious, you might next and get looked over, and they're human. They make mistakes. They miss things. And so if you come in with your list, like, wait a minute, I turned 40 this year. Shouldn't I have a mammogram? And they may go, oh, wait a minute. You sure are right. Or if you say, hey, I have a family history of colon cancer. Shouldn't I get screened early? Right? But if you don't know what you should be having, or if you don't know your family's history, how can your doctor advocate for you if you don't?
So with that being said, how do we, where do we go to get, and not to become Google doctors and nurses and all that stuff, because there's a lot of information out there, but where do we go to get accurate information? As we all have children on here, and so when we take them for their, yearly exam or wellness exam, there's a milestone developmental type thing. So where is that information for adults? At this age, you should do this, and to educate ourselves so that we can become better advocates for ourselves, and then for those who are taking care of elderly parents and things like that, how do we, stay connected with their information too?
That's a good question.
So the best way to do that is to start off by knowing your history, right? The reason why you don't see you don't go to the doctor and you necessarily see a whole list of like when you do for kiddos, when it's like, okay, you're 6 months old, you're going to get this, and this. Yeah. Well, what I need at 40 may not be what you need at 40 because you and I don't have the same genetics. We don't have the same family tree.
Right.
So, for example, if there's 4 or 5 of your primary relatives, your mother, your father, your brothers, sisters, grandparents, that have cancer, breast cancer, you need to be screened for BRCA1, BRCA2, right? I don't have a family history of breast cancer. So screening for BRCA1, BRCA2 is not high up on my must-have list, right? However, colon cancer runs in my family. So I need to know, well, what age was this person diagnosed at? Because screening starts 10 years before the age of their diagnosis. So if grandma was diagnosed at 60, okay, you're supposed to start your colonoscopies at 50 anyway, but maybe you'll start at 45 because you have a family history.
Wow.
If prostate cancer runs in your family, okay, and Paw got it at 50, well, then that means all the sons and grandsons need to be screening no later than 40. But there's no way to give an algorithm for that because everybody's different. So the first thing you need to do is your family history and know who has what. And I'm going to tell you, our people are notorious for being like, she died in her sleep. We don't really know. She has some kind of cancer.
No, man, no.
That's not medical history.
Pause right there, Dr. Kellee. So if we need to get screened earlier for things, how does that work with our insurance? Because does that then work against us having to wait? Because at 50 is when you supposed to get it, so then it will be covered. But I need to.
Now let me tell you about insurance companies.
Okay,
they would rather pay for you to get a screening exam than to pay for you to have chemo for 10 years.
That's
so good. The documentation that is necessary is the family history. You come into your doctor. My grandmother had colon cancer. She was diagnosed at age 50. I need to start my screening at 40.
Gotcha.
When you come with your medical history, that's why they have you fill out that paperwork. And the vast majority of people do not do their due diligence and fill it out. So then when your doctor is looking at it, you didn't write anything down about anybody having cancer. So why would they screen you early?
Yeah.
Right? So then when you show up 10, 15 years later and have cancer and your screening wasn't supposed to start for 2 or 3 more years, that miss is not necessarily on your doctor. Your family history tells us a lot about what we need to be doing for you. So family history is super important. We don't care about your husband, or if you're a male, we don't care about your wife because they are not genetically related to you. People do think they're family, but they are not genetically related to you. So your husband's mama's cancer has nothing to do with your screening, okay? You have to get your biological people's history. So, and a lot of times people don't remember.
Yeah.
And that's also what puts us at a disadvantage. It's because they didn't keep a lot of records about things that happened to us early on. So you may only know 1 or 2 generations, right? And so depending on what a person died from doesn't mean that they would not have been predisposed to having cancer. If you drink yourself to death and you're dead by 30, well, there's no history there. So then the people that come after you don't have anything to go on. So then you're getting screened later based off of the general recommendations when in your genetics is cancer, right? So we really have to be diligent going forward and trying to get as much information from our relatives as possible. Okay, I know you said she had cancer, but what kind?
Right.
Where was it? Right? So all of that stuff is important. And that is how you advocate for yourself. You're like, you know what? When I filled out that paperwork, I think I neglected to mention blah, 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 blah. Right? And so let me also say that there are a bunch of medical societies and groups that have really important data that is not Google, that doesn't send you down, a rabbit hole of, oh Lord Jesus, I got cancer, right? It's information that is used to guide you and inform you of things that you should be aware of, right? So the American Cancer Society has guidelines for breast cancer, colon cancer, whatever cancer you have in your family. You can look that up without being on Google looking up a symptom. Right? That's not the same thing. So American Heart Association has fantastic guidelines when it comes to blood pressure, talking to you about stroke, all of those things. So you have to be on the right sites. And I was really intentional in my journal about putting some of those sites. American Diabetes Association, fantastic information for patients. That's the type of stuff you need to be reading. Do not Google left hip pain or, because next thing you know, you're like, Lord Jesus. Right. Exactly. So it's really about educating our people about how to advocate for themselves. And Google is not it.
And teaching your children too. So this is good for us in our age to, share with our kids about maybe our ailments or, our history too, so that they are aware. I mean, I know a bit about my grandparents, but like now having to take care of my dad right now, I'm learning some things about him, but, just being able to pass the information along. So I'm so glad you mentioned that too. Get your history, y'all.
Get it.
Whoever's alive, somebody go to the doctor and get with the people, please.
For real. Terrell, you had a question? Oh, we can't hear you, Terrell.
Unmute.
Man, you had to type that in the chat.
Oh, come on, Terrell. Oh, man.
That's cold. It looked like the way you was talking, it looked like it was going to be a great question.
I know, right?
Type it in the chat.
Type it in the chat, Terrell, and then we'll make sure that we read it out. Okay, so while she's doing that, I guess my next question, and it was really Erica's question, so I'll ask it for Erica, because the question was, at what age, if any, should parents become concerned with childhood obesity?
Oh, that's my question.
And then any tips or suggestions can you give to parents that are concerned?
Because I'm concerned, because my kid want to eat all the time. So I'm like, is this a growth spurt at 6? Like, help me out, please.
So let me say this: childhood obesity is out of control. I don't personally see children, but the American diet is the reason, and everybody's busy, everybody's working, doing 15 different things, and so it's very easy to slide through a drive-through. Here you go, and we keep it moving. The answer is, and I know a lot of schools have gotten rid of exercise, PE. We used to have to go and run. We had recess. A lot of those types of physical activities are done because what are they doing? They're doing this.
Plugging in.
Right. They're all in front of tablets. And so there's nothing, we used to be outside. We ran, we jumped rope, the boys played football, we played basketball. We were more active. There's more gadgets now, right? And people like that because their kids will sit down and shit up, right? But they're not moving.
Right.
And so when you're outside and you playing basketball, you're not hungry.
Right.
Now you hungry when you come in, but if you're sitting in front of the TV or sitting in front of a tablet, you just. And now that everybody's home, or when we went through that spurt of people, the kids being home and homeschool, well, they at the refrigerator every 5 minutes, and that does not happen at the school.
No. Right. I had to tell them today. How many snack times are you getting in school? Because you got about 8 snack times here.
Kellee, they came to ask me for a popsicle today. I said, ma'am and sir, you would
during the day
a popsicle at school.
No, you would not. You would not. But that is now they're like, but we home. We home. And so part of it is discipline. and being like, go outside. I don't care what you do. You want to go walk, you want to ride your bike, whatever, getting them involved in activities that keeps them moving. That's part of it. That was actually one of Michelle Obama's platforms, was because our kids are sedentary. They sit down all the time. And now it's even worse, because even at the school, at least they had to get up and move around. Now they sit in front of a computer all day. So they're really not moving.
They really can't move.
Yep. The other component is, like I said, diet. Flat out diet. When I was a kid, I got McDonald's when my father picked me up from school, which was rare. When my mama picked me up and I was like, can we get McDonald's? She was like, I got McDonald's at the house. And I was like, I don't want meatloaf, though.
Not McDonald's.
Yeah, I don't want meatloaf. I don't want chicken. I don't want mashed potatoes, right? And so fresh fruits and veggies, our diets are just trash, honestly, as Americans. And we are eating out of convenience because we're busy. And so the diet, exercise is really the only way to get around that. Now, some people is genetic, but most of us is diet. Most people can control the variables if you are eating the proper things. And again, it's going to come down to, can you afford the proper things?
That leads to my question, Dr. Kellee, about the diet, and some people it's genetics. So for me, it's understanding my metabolism and understanding like how that works. And, I know we should drink our
body weight,
half our body weight in ounces and things like that. Right. But how do we better understand like what diet works best for our body? Because we all don't have the same body. We all don't have the same genetics, things like that.
So the cheap version, the cheap version of that, or answer to that, is trial and error. And the real easy thing I'll have you remember is that you have to burn more calories than you're eating, right? So I don't care what your metabolism is. If you're eating 5,000 calories a day, you're going to gain weight, period. So if you're trying to lose weight, you have to be really intentional about what you're eating. And so even if you go on like Pinterest and type in 1,500 a day, diet, they'll break it down for you. Eat some oatmeal, have a little piece of toast for a snack, have some apples, have a little peanut butter. Like, they'll break it down for you meal to meal. And if you follow that directly, you're going to get 1,500 calories, nothing more, nothing less, if you stick with what they've given you. So that's the poor man's version of like going to a nutritionist, right? If you're pretty disciplined and you just need some guidance, I would suggest looking at something like that. Because it's super easy and you can just flip through them and find something that you like.
What about those of us that are undisciplined, Dr. Kellee?
Okay. So if you're undisciplined, then you're probably going to need to either do one of two things. You're either going to have to get a coach or a trainer that will do your meal plans. And you can also have somebody do a meal service for you. Again, now this ain't cheap because somebody else is cooking and prepping your meal.
Paying, so I got to do this.
Yeah. So meal prep is an easy way to do that because somebody else has proportioned your sizes, your quantities for you. And you're letting them know, listen, I need 1,500 calories across 3 meals and go. Right. And they got it for you. That's one way to do it. The other is if you want to go the poor man's way, but do it with an accountability partner. And you can keep each other accountable. Like, okay, it's 10:30. Did you eat your apple? We were supposed to have an apple and some pineapple, some apple and some peanut butter today. Have you had yours? Are you staying? How much water have you had today? So you can do it that way. That's cost effective. But essentially, you have to move.
Yeah.
If you want to lose weight, and it doesn't take a lot, especially the more weight you have to lose. The closer you are to your goal, the harder it is to lose. Right? You'll see people who are 400 pounds. They'll be like, "Man, that first 150 was easy. It was the last 30." that about took me down, right? Because you're getting closer. So it requires you to keep pushing yourself and to get more disciplined, to get stricter so that you can finally lose the last little bit. So things as simple as eliminating soda from your diet. You'd be surprised how many calories that is a day. And if you actually keep a food journal, like most of us think, okay, we're eating pretty good. But if you actually write down every single thing that you're eating, you'll find out, oh, snap, that's 2,500 calories.
Yeah.
That's why we're not making any progress.
Right.
So you don't have to be necessarily down to the like 1,500 exactly, but you have to watch the stuff you're snacking on.
True that. I see Terrell's question, and it was it's in our private chat. It looks like when you have blood work done, does it pick up on cancer or any other diseases?
Okay. Cool. So the short answer to that is yes. The long answer is it depends. And it depends on what kind of cancer you're looking for. So if you are looking for a cancer, so we don't look for cancer in our blood markers, if that makes any sense. So when you come in and say, okay, I've lost 15 pounds or whatever, and I wasn't intending to, and, let's say, and I've noticed that my bowel movements are smaller. Okay. So now you're guiding me in a certain direction. So I'm not about to order $15 million worth of labs. I'm taking your history, your family history, and I'm honing in on what's most likely. And so there's certain keywords and things that you may say or things in your history that will guide me towards certain cancers. So if you tell me, okay, the caliber of my stool has changed, it's thinner, it looks like small, and I've lost weight, well, I'm looking for a colon cancer. So I'm going to send you for a scan of your belly, and we're looking for something in your GI tract. Right. If you tell me, you know what, I've lost 15 pounds and you're a heavy smoker, there's no need in me looking in your colon. I'm looking in your chest. I need to look at your lungs and possibly at your throat, because you could have throat cancer or laryngeal cancer, anything head and neck for our smokers, right? So this is why history and taking good history from our patients is so important, because you don't want me to order a battery of tests, paying out the wazoo for me to be like, oh no, that wasn't it. That wasn't it. That wasn't
a bill from Quest Diagnostics. Okay.
Exactly. So that's why we ask the questions we ask. When did it start? How long has it been going on? Family history? We ask certain questions because we're trying to, it guides our decision making. So yes, once we figure out,
what do you think of diet soda?
Yeah, that's on that. Now I'm gonna throw out that the shade is specifically from my husband.
Okay.
I'm a big diet soda, Coke Zero drinker.
Aspartame.
So I'll tell you, right. So I'll tell you what I noticed.
Yes.
Lately, is that I gain weight. Like, so what happens is this is what happens. Real talk.
It's a ton of water.
Real talk. I drink diet sodas. So during the week, I drink 100 ounces of water every day.
Every day.
Okay.
On the weekends, or like if I'm home chilling on vacation, I don't drink any, now I'm focused heavily on the diet sodas. And so then I see a weight gain. Then when I go back to the 100 ounces, it starts moving. The weight starts moving back down quicker. And so I just saw my husband the other day. I'm like, I think maybe something's in the diet soda. I don't know. So I don't know. It could be. I don't know what
it is. That's what it is.
So
drop the diet soda.
Yeah. So I mean, when you take in anything, even diet soda, it has less calories, it has less sugar, or it has a sugar substitute. But at the end of the day, when your body is processing it, it doesn't care what type of sugar it is, it still translates to sugar. So if you are a person who likes diet soda, then maybe you could have a cheat day and say, okay, and not the 12-ounce can, but the little 8-ounce joint, right? And you could say, okay, Friday is the day we usually eat out or eat pizza or whatever the case may be. That'll be my cheat day, right? Every other day, I'm gonna drink water. And then there's some other substitutes that give you the sensation that you're having something more than water. Like you can put the little drops in, or you can use the little packets. And so those give you the sensation like you drinking Kool-Aid and you're not, right? It's not all the extra sugar that we require. So you have to just kind of and that's the thing. Little cuts make the difference, because if you do something drastic, you're not going to keep it. Right. You could be like, that's it. Especially if you're like, right. If you're a bread person and be like, today, I'm just throwing all this bread out. Next week, are you going to have that same energy? In 2 months, are we still giving up bread? Or does it seem more realistic to say, okay, I'm going to limit my bread to once a day. And then I'm going to try to do it twice, 3 times a week. And then let's see what we can live with. And that way you're not completely cutting things you like out of your diet. It's about moderation, not anything drastic. So obviously don't just eat what you feel, when you feel, however you feel. And then don't be like, okay, all this got to go. We eating carrots from now on. That's not sustainable. And nobody's going to want
I want you to get out of my house, Dr. Kellee.
Tomorrow. That's all of our houses, right?
So for success, y'all.
Right. So the last question, I know we're out of time, but one of the questions that we all had, we're all kind of turning that 40. Or I'm over 40. But the question is, I think supplements, vitamins, what is it that we should be taking to, to really ensure that we're getting the nutrients that we need at 40?
Okay. So honestly, if you're eating a balanced diet, you don't really have to do a lot of supplementing. The reason why Americans really need to take multivitamins is because our diet is trash. And so we all love a good Popeye's chicken sandwich. But what we need nutritionally is not in that sandwich, right? And so that's really where the multivitamins come in, is because when your body is trained to take the nutrients it needs and dump what it doesn't. It doesn't store up, a bunch of stuff just to have on a rainy day, because the thought process and the design, the way God designed us, is that every day you're giving your body what it needs, right? So you can't be like, well, Saturday I drank 4 gallons of water. I don't got to drink water the rest of the week. That is not how it works, right? Your body on that Saturday is going to take the water it needs, and what are you going to do for the rest of the day?
Flush it out.
Goodbye. Tomorrow is a new day. It is not holding on to that water just in case.
Just like
that is not.
No, you can't. No.
Right. This is not that. So your body is going to take what it needs and flush the rest. So the reason we use supplements and multivitamin this and that is because we don't eat right. So if you ate a balanced diet, fruits, vegetables, lean meat, you can cheat, and have your steak or whatever else, or your fried chicken when you want to, but that has to be the exception and not the rule. You have less of a need for supplementing when your primary diet is adequate.
That's awesome. All right. So Dr. Kellee, as we close out, is there, I know you started in the beginning, just kind of sharing and plugging some of the great work that you're doing. I want you to just kind of close this out again and point us to any websites or anything like that where we can reach you and contact you.
Absolutely. So thank you again for having me. I hope we can do this again. This was a lot of fun. And this is exactly my target audience, because who's going to come and talk to you like this unless you look like me, right?
Okay.
So thank you again for having me. And I am Dr. Kellee. I'm a board certified internal medicine physician, patient care advocate, speaker, and soon to be author. And I am committed to ending healthcare disparities for Black and Brown communities. So I have created a healthcare journal because I want patients to be informed and to be able to advocate for themselves, to have all their information in one place, and they don't have to guess. They don't have to pull it from the purse or under the gum and the bottom, under the makeup. I want you to come in like you mean business and be able to advocate for yourself. So I would love for you to visit www.mymedicaljourney.shop and support. I am launching my website very soon. And that will be www.drkellee.com. That's DOCTORKELLEE.com. And I am on all social media, Facebook, Instagram, Twitter, you name it, as Dr. Kellee. And I will be more than happy to work with you. I will be launching a coaching program in 2021.
That's awesome. Thank you so much. This was
You're welcome.
And so, yes, we will invite you back. And so, guys, just remember, Brothers on the Block is on Monday, Sister Circle is on Wednesday, and Victory Baptist Church always on Sunday mornings. So we invite you to join us then. Other than that, guys, have a great evening, and thanks for joining us.
Family history.
That's right.